Okay, so here is my presentation. We had submitted a paper in our journal that neuroimaging in refractory epilepsy with post-surgical outcome. That is a current practice and evolving trends. So what we are doing for these kind of refractory epilepsies and how the surgical outcome is better. As we had done a lot of patients, basically more than 400 300 to 400 surgeries in our institutes. So this is my institute in Pune, India. So because epilepsy had a 1% of world's population, there are a lot of patients. There is a 20 to 40% refractory to the medical management, and especially the temporal lobe epilepsy is the most likely to be refractory. So focal onset of seizures occurs in 60% of these epilepsy patients. So it is very important for detection of the dysplasia, and area of interest is neuroimaging is very much helpful, as it is most of the types are focal. So the in these kind of patients, surgical outcome is also better, as we had very good imaging tools. So we found mainly the temporal lobe lesions more. It is a 59%. The frontal, then frontal lobe lesion, that is 21%. Then parietal, and least is the occipital. So we had done the callosotomy in 40%, the tumor or lesion resection in 30%, and deep brain stimulation in 20%, and redo surgeries because of there is no seizure free outcome. So in 10% of the patients. So these are our imaging protocols for the new onset of seizures, mainly the causes like infection, metabolic, stroke, neoplasms, autoimmune, or post-trauma. We do the sagittal T1 weighted, axial T2 weighted, the diffusion weighted, and susceptibility imaging like SWI. So, especially non-epilepsy patient, we had patients for the mesial temporal sclerosis, cortical dysplasias, cavernomas, then neoplasms. We do addition of the sequences, mainly the T1 MP range and the coronal T2 images. So, little bit the anatomy of the temporal lobe, the superior temporal, middle temporal, inferior temporal gyri, the fusiform gyri, the parahippocampus gyri, and the hippocampus. So we found hippocampus sclerosis or atrophy in 30%, the tumors in 22%, mainly the gangliogliomas, low-grade gliomas, and DNET. Hematomas in 11%. Then disorders of migration or cortical genesis and gyration are 10%. AVM and cavernomas in 8%, and glios is mainly the post-traumatic or encephalitis is 7%. So the anatomy of little bit the anatomy of the hippocampus. Here we see that there are 7 parts, mainly the hippocampus cornu-ammonis, the labeled as a number 1. Then 2 is the hippocampus gyrus. The third one is alveolus fimbria hippocampi. The fourth is subiculum. The fifth is gyrus parahippocampi, and the sixth is gyrus fusiformis, and seventh is the fornix. So mainly coming to the mesial temporal sclerosis, it is the most common pathology found, the rare under age of 10. Mainly the pathogenesis we found the post-infectious, post-ictal, and febrile convulsions. We use the criteria to diagnose the hippocampus sclerosis is atrophy, the hyperintensity, loss of internal architecture, and loss of digitations. These are the few signs. Also, there are few secondary signs, mainly the unilateral, ipsilateral mammillary body, and fornix atrophy. So here we can see the right hippocampal atrophy. The major temporal sclerosis, we found the size of the hippocampus reduced in 80 to 90%. There is a loss of internal architecture in 90%. Signal intensity is found in 65 to 95%. So there is associated bilateral involvement in 10 to 15%. So whenever there is a dual pathology, there is always difficult to diagnose. So we had a criteria for detection of bilateral hippocampus. Mainly, we compared the signal intensity with the cingulum, and if the signal intensity of the cingulum, if the signal intensity of the hippocampus is more than the cingulum, then there is a certain abnormal signal in the hippocampus is considered. We do few patients MR spectroscopy, but we had a very poor results. And we had done volumetric analysis by using the few tools. Mainly, these tools are available in the market, like artificial intelligence. So we calculated exact data of the hippocampus volume, and we had compared. Here we can see we can nicely see the hippocampi right and left. So there is a bilateral volume loss, and we get the exact details of these kind of hippocampal atrophies. So we do each and every patient's the tractography also. Whenever there is a surgical patient is undergoing any surgeries. For volumetric analysis, the visual analysis, we had classified into 125 patients. We had a very good examples, like by visual analysis, there is less number of patients we had found as compared with the automatic volumetry. So the automatic volumetry having the 95% sensitivity as compared with the visual analysis. So on imaging findings, we had done a differentiation table. Here we can see the hippocampal sclerosis, recent seizures, the signal intensity is very high. There is atrophy in hippocampal sclerosis, but in post-ictal patient, there is no atrophy. In case of cortical dysplasia without balloon cells, there is a signal on flare is normal, but the cortical dysplasia of Taylor type 2 cells, that is balloon cells, are present, then the signal is very high. We found in DNET and gangliogliomas, there is a calcification present in gangliogliomas. However, in DNET are less. Out of one-third patients, we had found minimal calcification and hemorrhage in DNET. So here are the few examples we had seen. The left hippocampus, there is a hyperintense signal. Here we can see the T2 axial and T2 coronal images. And in post-op, we had removed all left side hippocampus and the left temporal lobe. Again, similar case which is having similar signal intensity, but there is some cystic appearance in the left hippocampus, and there is a peripheral enhancement with mild perilesional edema. So on SWI imaging, we found this is a there is a susceptibility, blooming artifacts are seen. So most probably this is a vascular structure like cavernomas. So we found vascular malformation, cavernous malformations, AVM, capillary telangiectasia as developmental venous anomalies like venous angiomas. So these are frequently multiple 20 to 30% of the cases. These are familial pattern in 10 to 15% of the patients. The seizures are common in 40 to 60% of patients. From it is said that from the irritative effects of hemosiderin and gliosis and compression of the adjacent cortex, these seizures are seen in this case of cavernomas. So another similar case with a typical blooming artifacts in the left temporal lobe, predominantly involving the hippocampus. So there is a large vein is seen. This is a case of arteriovenous malformation. So this patient is undergone surgery and there is a very good outcome. So similar case of left hippocampal atrophy, but there is associated findings in the left temporal lobe. There is a white matter paucity is seen, which is confirmed on T2 axial images. This is a transmental sign. There is a large dysplasia in left inferior frontal lobe. So few findings, mainly the syndromes which are commonly seen. There are certain areas, these are the nodules which are seen in subependymal surfaces, and also you can see the subcortical hypointensities on T1 coronal images. So, which is confirmed T2 hyperintensities in subcortical regions of frontal, temporal, and occipital lobes. So, this is case of tuberous sclerosis. These are the dysplastic stem cell in the germinal zone, results in disorganized collection of dysplastic glial or neurons. There is a cortical hematomas, white matter lesions, subependymal nodules, the giant cell astrocytomas. Mainly the triad of symptoms are seen: mental retardation, epilepsy, and skin lesions. As we are doing the surgeries of tuberous sclerosis, basically we see there is an area of calcifications or areas of blooming on SWI images. So these are the active tumors which are leading into the seizure out, which are firing the seizures. So these tumors mainly in the subcortical region, which are confirmed on EEG findings and PET CT findings, and these tumors which are mainly concerning the semiology of that part are removed, and there is a very good uh, seizure-free outcome in tuberous sclerosis patients. So coming to the infections, small lesions which are leading into the seizures like neurocystic which gives typical central peripheral enhancing and central dot sign, which is seen in neurocystic. These patients are treated medically. Coming to the another large infections which are already patient had undergone, like complete atrophy of the left cerebral hemisphere. Here you can see the T2 axial and T2 coronal images, which are commonly seen in Rasmussen's encephalitis. In these kind of patients, the surgical outcome of callosotomies are very good. So coming to the tumors, few tumors we had seen in case of temporal lobe involvement, mainly the bubbly appearance of these cystic lesions seen in left hippocampus. These are the DNET. These are completely removed area of interest, and the seizure outcome is good in these kind of patients. So few large tumors we had found, mainly the ATRTs. These tumors shows multiple enhancing areas, the central necrotic areas which are causing mass effects, and there is a midline shift. So these typically seen in younger age group. The cerebellum involvement is 60%, the cerebrum is 20%, and these are indistinguishable from medulloblastoma, but response to chemotherapy is poor. These are having large necrotic mass, calcifications, and thick enhancing nodular rind. So we found few lesions which are easily missed on imaging part, but as we see the semiology and all, there are small encephaloceles. Here we had presented a paper in epilepsia that gyratory seizures as a presentation of temporal encephalocele. Here the arrow is showing that small encephalocele in the left anterior temporal lobe. There is typical signs of encephalocele, mainly the little bit distortion of the left anterior temporal lobe with thin rim of CSF is seen on T2 weighted images. The below color image shows there is a hypometabolism on PET scan. These findings are confirmed in the surgical point, and this patient is seizure free now. So it is a teamwork mainly. A good diagnosis need a good scan. Coming to the conclusion of my topic is patients with epilepsy should be evaluated by a dedicated 3T MRI seizure protocol, and we will find uh, most of the patients we found the reasons. The primary role of MRI is to define structural lesions, and the surgical outcomes are very good in case of seizure free lifestyle. Most of our patients having seizure free lifestyle. The future Functional MRI and artificial intelligence tools in brain volumetry will play a greater role in preoperative evaluation. Thank you.